No problem. So this is important. Both are risk factors. So a person can have malignancy with pre-existing cardiac problems. Stent लेंगे से 45 years old female, 50 years old female, आपने CA breast हो. Okay. Or a person has malignancy but gets cardiovascular issues later because of medicine. So these are the cardiotoxic drugs which cause थोड़े को लाभ नहीं. The answer is all drugs are causing. It can cause LV systolic dysfunction with heparin. You can have arrhythmias. You can have thrombophilia with thrombosis. Patient can come with ACS. You can have pericarditis, bleomycins. You can have ischemia. Right? More potent the onco medicine, more toxic. आजकल imatinib, nibs गुण ऐसे कैसे, which are monoclonal antibodies, more cardiotoxic, right? So it is mandatory for you to understand what is the toxicity. So the guidelines came in 2014, and it is going to change, and they have divided in them into type 1 and type 2 toxicity. Type 1 toxicity, the classical example is adriamycin, doxorubicin. They cause cumulative toxicity. First dose dilam, 3 weeks se pore second dose dilam, toxic bedegalo. Third dose bedegalo, aro bedegalo. It is called cumulative. It is irreversible. While type 2, it is HER2 receptor blocker, trastuzumab, imatinib are dose dependent. Dose dilam, toxic, normal. Toxic, normal. Dose dependent. So adriamycin is cumulative and trastuzumab is dose dependent. Single dose toxic, normal. Right? So now, if you know that CA breast is, for example, they give adriamycin, cyclophosphamide, two-tinted drugs that. So the maximum dose never goes beyond 350 milligram per meter square in life of a person. Because 400 and over the risk of cardiotoxicity increases. So that's why the oncologists give a combination of two tinted drugs. আপনারা ভাববেন কি অনকোলজি কি মেডিসিন দিচ্ছে আমাদের কোনো কাজ নেই না আপনার কাজ আছে you should know basis of medicine is important. So these are the guidelines and we do three things. The first two is not possible. You do echo, you do biomarkers, and you cardiac MRCT. All patients should have either of them, two of them for sure. Okay? Unfortunately, cardiac MR is expensive, so you do two of the first two. And this is what is needed. Okay, so I will tell you. First is, you have to measure EF by 2D Blaine Simpson or 3. There is no role of 2D by MOS. Second, give them volumes. LV, EBV, LVSV. That again comes by Blaine. You can consider CMR in some cases. You have to use biomarkers. Troponin, NT-proBNP. Always give blood pressures. The reason of sitting here is to add to whatever you are practicing and measure GLS in all patients. So ejection fraction, GLS, blood pressure and biomarkers. Interestingly, there is no E and E by E prime. It's not there in the recommendation. Okay? So this condition is called CTRCD. আপনাকে diagnosis এ লিখতে হবে cancer therapy related cardiac dysfunction. This is an entity which will be asked for your MD exams. Sir, জিজ্ঞেস করবে এক্সামে আপনাকে what is CTRCD? Right? So CTRCD involves only two things, EF and GLS. Bas. And the first thing is a decrease in ejection fraction of less than 10 percentage points to a value less than 50. ঠিক আছে এটা এখন এটা দেখবেন just means what I will give you 4 5 examples. First day patient আসলো কোমাতে যাচ্ছেন কি ফুড কোমা না ফার্স্ট ডে পেশেন্ট আসলো আমি বললো কি আমার সিএ ব্রেস্ট সার্জন আপনার কাছে পারচেজ ফিটনেসের জন্য অনেকবার আসে আপনার কাছে গেট অ্যান একো গেট অ্যান ট্রপিন প্রোটিন এकोতে কি থাকবে বেসলাইন করলে EF by pipeline is 60%. You will say patient is fit for first dose. Particularly, tropin protein is normal. Next dose and आगे ashlo, you see the EF is 51%. Means what? 10% of 60% is 54. Anything less than 54 is LV dysfunction. You have to start in or on ACE inhibitors, carbendazole statins. This is one scenario. First patient, ashlo 60%. Second follow-up with EF is 57%. Is it less than 10%? The answer is no. To GS. First time ashlo, you see it is 45%. Already LV dysfunction. You cannot start him or her on if the patient is not on ACE, carbendazole, statins. Tell the oncologist that she already has cardiac dysfunction. You manage the treatment. You have to explain to them. Always take protein. These are 3 scenarios. So 10% reduction is baseline PK for the format. So that is the reason the LVEF guidelines have come to 52 because the cutoff is 53 and these are the various studies. I mean, one is a kalke bola chamber quantification right. So these are the studies which has done. Second is strain analysis. First time chemotherapy test strain was -18%. Normal is -19. Or follow-up is -16.5. There is a 2% change. Next patient chemotherapy GLS is -19.5, but now GLS is 10.5, 10.1. Severe LV dysfunction. So what does it say? It says if you are doing GLS less than 8% relative reduction, there is not problematic. But if it is more than 15%, it is CPRCD. So I will again tell you the definition. Listen. First scenario. First patient 60%, follow up at 51%. Directly CPRCD will come. First patient LV 60%, GLS -20. Second time जब हम कर ले 57%. 10% reduction, but GLS has gone to -15.1. 15% reduction of 20 is 3%. 15 into 2 is 3. So -20, -17 and नीचे बोलो CTS. So we need two things: LVEF and 15%. And what is written that GLS of anything more than 18% is considered normal. If it is less than 16%, it is surely CTS. वही patients के अपने के medicine दी. And this is what it shows that if there is a drop of more than 10 CTRCD, but if the relative drop is less than 8, no problem. If it is more than 15%, there is subclinical LV dysfunction. Please start this patient on ramipril, beta blockers, statins. Role of SGLT2 is being investigated. There are a couple of reports which have come up. They have shown that it is helpful, but guidelines are ashini. But if the patient is coming with drop I positive, manage him as an ACS patient. So now, how frequently it is to be done? Often korbaras, right? So write it down. If you are going for a surveillance of a patient, so echo has to be done and biomarker has to be done always. Biomarkers keep troponin and protein, right? So they divide it into ASCVD score, atherosclerosis score. Let's say everybody is in the high risk. So do baseline, second cycle, fourth cycle, 3 months, 12 months. Dekhe now, you will remember it for cyclophosphamide. It is baseline 2, 4 cycle. That means 21 days a diagram. After 3 months and 1 year. It is type 1 toxicity cumulative. Baseline, troponin, proBNP, second cycle aage, fourth cycle aage, 3 months cycle aage, and 12 months cycle aage. While for trastuzumab, again ASCVD iris, you do it second cycle, fourth cycle, 3 months, 6 months, 9 months, 12 months, 15 months, third year. So you write baseline, second cycle, fourth cycle, 3 months, 6 months, 9 months, 12 months, 15 months, 3 years. এটা আপনাকে করতেই হবে লিখে রাখবেন অ্যাডভাইস পেশেন্ট আসে না আসে দ্যাট ইজ ইজ আদার ওয়ে বুঝতে পারছেন baseline second cycle fourth cycle 3 months 6 months 9 months 15 months 3 years and why this is important because if you have an anti-proBNP or troponin negative that means troponin কোনো injury নেই anti-proBNP কোনো condition নেই fine follow up पे देख लें अपने troponin positive but anti-proBNP negative that patient is getting blockage radiation out there can affect you have to add aspirin and advise an angiogram troponin positive is myocardial injury if you are getting troponin negative anti-proBNP positive look at the IVC additional whether the patient is having failure maybe a diuretic may be needed of course ACE inhibitors upper needs but if on follow-up we have both positive very problem you have to get an angiogram to all those therapies. So treatment is same as heart failure treatment is same as disease I'm simplifying cardio-oncology a lot. We have learned CTR, CD. We need echo, troponin, proBNP. If you are unconclusive, you can get a cardiac MR or CT. But type 1, type 2 toxicity is needed. When to do, I have already told. For type 1 is baseline, 2, second cycle, fourth cycle, 3 months, 12 months. For trastuzumab, baseline, 2 second cycle, 4th cycle, 3 months, 6 months, 9 months, 15 months, 3 years. Coffee for everybody? Yes. Somebody. Coffee for everybody. Including me. Coffee check. Every toxicity with CPR.
I'm not a fan.